Welcome to Brainwaves. I am Professor Kapoor, the Executive Dean of the Institute of Psychiatry, Psychology and Neuroscience, King's College London. Brainwaves is our series exploring and explaining the latest in mental health and neurosciences research.
I'm Carmine Pariante. I'm Professor of Biological Psychiatry in Psychological Medicine. I've always been interested in the role of the immune system in depression. In fact, my medical degree thesis in 1991 was on this topic. And it's really amazing to see how this field has grown over 10 or 15 years from being quite a niche scientific area to mainstream scientific research and now actually close to be mainstream clinical practice. In this new paper, we measured the level of inflammation in the blood of depressed patients. And what we noticed is that if people had high level of inflammation, they were less likely to respond to antidepressant. And in fact, for those that had very high level of inflammation, and we could actually measure the specific threshold as we do for a blood test, for those above the threshold, for those with, if you like, positive blood tests, their chances of responding to the antidepressant was virtually zero. The reason why we think that this approach is important is that normally the treatment of depression just happens to trial and error. There's a large number of antidepressants which are available for prescription, and what normally happens is the physician just prescribe one, wait for a few weeks to see if the patient improves, then if the patient doesn't improve, they try another one, wait a few more weeks, and so on and so on. And we don't know at the moment whether the individual patient can or cannot respond to the standard antidepressant that are commonly prescribed. So the potential of having a blood test that tells us whether someone will or will not respond to a standard antidepressant is that for people that are normal, the blood test, so their level of inflammation is below this high threshold, then we know already that they are likely to respond to conventional antidepressant, and we would prescribe them with more confidence in their success. But for someone that had higher level of inflammation with levels above the threshold, then we would skip to what we call more assertive strategy of antidepressant treatment. For example, combining more than one antidepressant together, or potentially combining one antidepressant with an anti-inflammatory. And we could do that much earlier rather than just waiting for months and months until we realize that that person is not going to respond. We know that only 50% of all depressed patients respond to the first antidepressant that is prescribed. And actually a third never respond even if they're prescribed a number of antidepressants. People always ask me why depressed patients have high level of inflammation. What is the reason? And what we need to understand is that having high inflammation is just part of the normal stress response. Our body is predisposed to react to a situation of stress as if the stress is physical. And having high level of inflammation protects us against infection, which would normally occur if, for example, we are in a situation in which we encounter a predator. So what we think is happening is that the level of inflammation is elevated in depression because depression, from a biological point of view, is a condition of chronic stress. Obviously, it's a mechanism that is not helpful anymore in modern society because chronic stress derives from psychosocial dangers and not from real life-threatening physical dangers. It's a mechanism that stayed with us because our body still works as if we were living in a jungle. Many patients often ask me, can we take anti-inflammatory for our depression because we are not getting better? But the answer at this stage is unfortunately still no, because anti-inflammatory have side effects. A combination of anti-inflammatory and antidepressant have potential even more side effects. And while this is something that we are pursuing in the context of research, it's just too soon to prescribe or to recommend to everybody to pursue. I'm confident that if we can conduct a large clinical trial to test this blood test or an equivalent blood test measuring inflammation over the next 3 to 5 years, then after that we would be ready to introduce this test in clinical practice. The important element to consider is that blood tests would allow us to use a personalized approach in the choice of the best treatment for the individual patient, which is becoming routine clinical practice in other medical specialties, for example, in the treatment of cancer. And this is the first time that we can actually bring personalized medicine right at the core of psychiatry.